So moving on to our panel discussion, which is on perioperative immunotherapy in head and neck cancer. I would like to invite Amish Vora sir, who is medical oncologist at Hope Oncology Center at Delhi. So, and the panelist will be Kumar sir from TMH Mumbai, Dr. TP Sahu sir, if he's there, from Silver Line Hospital, Bhopal, Anil D'Cruz sir from Apollo Delhi, Pankaj Chaturvedi sir is a surgeon at TMC Mumbai, Dr. Harsh Dhar is a head neck surgeon from SSKM Kolkata, Dr. Sevanti Limaye, she's a medical oncologist at HN Reliance Foundation Mumbai, and Dr. Shyam Agrawal sir, who's at Gangaram Hospital, New Delhi, is a senior medical oncologist. Over to you, Amish sir.
There are few changes, Preeti. So Kumar sir might be joining in sometime. TP Sahu sir and Pankaj Chaturvedi sir are not able to join because of some urgent meeting. Anil D'Cruz sir may join. So we are left with Dr. Harshadhar will be there, Dr. Sevanti is there, Dr. Shyam Agarwal sir is there, and Dr. Lakhan Kashyap is there, and Akhil will be also be there.
Yes. Dr. Lakhan and Dr. Akhil. And Amit, you are also there.
Yes, I am also.
Dr. Preeti is also there.
Yeah. I am also.
Preeti is also there. Perfect. Right. So, perfect. So we have Dr. Harshadhar as in head and neck surgeon, right?
Yes, sir.
And Dr. D'Cruz sir will be joining or he will not be joining?
Sir, he might join. He is in a flight, basically. So
he is in a flight. Okay. Dr. Pankaj and Dr. Tarini are not joining.
Not joining, sir.
Okay. Perfect. Fine. So we have this thing. Perfect. Is my slides moving? You people are able to see?
Yes, sir.
Yes, sir.
Okay. Perfect. So 20 years later, so topic is perioperative IO in head and neck cancer. And for last 20 years, we were struggling to get something positive. And I know that from the time Dr. Sevanti started practicing, the trials started becoming positive, Sevanti. So the credit goes to you. After 20 years, we we have two positive trials. One is Keynote 689 and second is Nivo Postop. So Keynote 689, we have all the details in terms of the detailed paper. Nivo Postop, we are waiting for further details. Advantage or similarity between the two trials is both were in the similar time period, that is 2019 to 2022. They have a similar follow-up of 30 to 35 months. And both achieved their primary endpoint. I think this is something which is wonderful what we have. This is the New England Journal of Medicine article, which was published in June of 2025. And this was neoadjuvant and adjuvant pembrolizumab in locally advanced head and neck cancer, which is there. This is one of the author, Dr. Anupama Huda Nehra. She was my colleague and my head of the department in Max Hospital. So I'm very proud that her name is there. I contacted her. And this is today morning's downloaded NCCN guidelines, where already if the patient has PD-L1 CPS more than 1, neoadjuvant pembrolizumab, except N3 disease, is included in the NCCN guidelines. So I want to ask all the panelists right now, just yes or no, and then we will go into the details. Do you accept this change of practice, that is in locally advanced head and neck cancer, if the patient has more than CPS 1 and operable, you first give 2 doses of pembrolizumab? And let me start from Shyam Agarwal, sir. Sir is there? No, sir is not there. Okay. Perfect. Dr. Harsh?
Sir is there.
Yes, sir. Yes, Dr. Harsh says yes. Dr. Sevanti?
Yes.
Perfect. Dr. Lakhan? Dr. Lakhan? Dr. Preeti?
No.
Dr. Preeti says no. Excellent. We will come to that. Dr. Akhil?
Yes, sir.
Dr. Akhil says yes. And Dr. Amit?
Yes,
our
sir.
organizing secretary? Yes. So Dr. Preeti, you are the only one who's left out, and we will discuss about that, which is there. Okay. So, Dr. Sevanti, you are head of ethics committee, and Dr. Akhil has presented you with these two scenarios, where the first scenario is stage 3, stage 4A operable head and neck cancer, where you give 2 doses of pembrolizumab before surgery, versus you say let all the operable surgeries be operated upon. Then before RT, you give 1 dose of nivolumab. You have to choose 70 only one. Akhil says you can choose both, but as an EC head, you can choose only one. In Indian scenario, which is the trial you would choose?
Newer post-op.
Nivo post-op. Any particular reason for that?
So I may be seeing only a limited Indian side. So correct me if I'm wrong, but um the gatekeepers are surgeons. A lot of our patients come already post-surgery. And I find myself very rarely in the situation of Pembro. That's one reason. The second reason is cost. And I think that reason will be eliminated very soon with the utilization of the other molecules that have launched in the
Dr.
country.
Sevanti, Dr. Akhil says that I have full funding for both the studies, 100% of the
Yeah.
funding. And he
So,
assures you that patient will come to you before surgery. What
right.
I'm looking at the science behind both the trials. One where you give before surgery, one where you give before RT. Which is more scientific?
So the data is still going to play out. More scientific is to give it early for the priming.
So before
And
surgery.
so the earliest you give, the better it is if you are looking at the concept of immune priming. Having said that, the data has still not played out to its fullest, and we still just are dealing with DFS, and it will play out down the line where we will get more details. But the population that I serve, I see mostly already post-surgery, one, and there are practical challenges.
Practical. So you would go for Nivo post-op. Akhil, if you
For
have to
very
present,
religious reasons.
Akhil, if you have to present only one of the two, okay, in terms of science, which one would you choose either out of the two?
So, sir, in terms of science only, uh, actually, what we are already having another trial in terms of
ये दोनों में से कौन सा select करोगे?
resectable head neck cancer. We have a trial of metronomic plus low dose Nivo actually, 2 cycles actually. So that is one of the study. So going by the science, as 70 ma'am was also trying to highlight, priming it as early as possible will be one of the key for long-term overall survival. So that.
Keynote 689 is something which you would prefer, right? Pembro before surgery is what you would prefer. Perfect. Dr. Preeti, you said no for 689. Would you agree for Nivo post-op?
No. By scientifically point of view, Pembro, when the disease is there, then priming will be better. So I would agree with Sevanti ma'am as well as Dr. Akhil that Pembro pre-op would be better. If you ask me to compare between these two, yes, Pembro pre-op would be better.
Keynote
Scientifically.
689. Dr. Harsh, would you like to comment? Which one would you prefer if this has to go on the table today? See, both are positive studies.
Yes, sir.
But
So,
would you like to say which one?
yes, sir. So, having looked at both these papers, I mean, conceptually, definitely priming the patient in the presence of the disease, that seems more attractive. And yes, we have seen interestingly, there are, if you look at both the papers, sir, the pattern of survival benefit. When you've given in the neoadjuvant phase prior to surgery, you've had a advantage in reducing the distal metastasis. When you've given post-surgery as an adjuvant, the locoregional control has been better. So
What do you
definitely there
want
are
in your
advantages of
patients?
both.
What do you want, Dr. Harsh? What do you want in your patients in
I
India?
would definitely go for the neoadjuvant model. Having
Okay.
said that, I must point out, if you look at the paper in detail, compliance in the intervention arm, correct me if I'm wrong, is not more than 60%. And you've got
We will
17
come to that.
cycles of
We'll come to
nivolumab.
that. We'll come to Dr.
Right.
Harsh. So looks like that you also, if you have to choose between the two, you would go for pre-operative, right?
Amish, can I come in, Doctor?
Pre-operation. Yes, sir.
Shyam sir, we were waiting for you. Yes, sir. Please, your
Yeah.
comment.
No. So both are positive studies on the disease-free survival,
Yes.
and that too in CPS greater than 1. So there is no head-to-head comparison whether you do, after surgery or you do 2 cycles before in the Pembro. So I don't think that there is anything to choose between them. So if a patient comes to me after surgery, and because both of these are resectable cancers, so which are judged resectable, the idea is not to, make them operable. So these are resectable cancers in stage 3 and stage 4, so which are deemed resectable by the surgeon.
Right,
So
sir.
like you do in the lung cancer, where the surgical potential is clearly understood. The idea is not to downstage and operate. The idea is to assist by using the immune checkpoint inhibitors. So I don't see any data to support one over the other. So depending upon the situation, because surgeons are not going to stop operating all their patients right away. So if I get a patient
So
after surgery,
Shyam sir, today if the patient
yeah.
comes to you in the OPD before surgery, patient is operable, your head and neck surgeon says operable. Would you like to give 2 doses of pembrolizumab before surgery, or would you like to give nivolumab 1 dose after surgery before RT?
Right, since we have both the options, so we'll have a shared decision making in the tumor board and along with the patient, because both the options are going to be open.
Both
So
the options.
I would
Perfect.
not like to, it's not like that you have established that in a patient who is HER2 positive or TNBC 2 centimeter, all should be given, the targeted drugs. So here you have both the options open.
I,
That is
I
my take.
agree with Sir Amish that it is about when